Good afternoon. Thanks for joining us for Mentor-Mentee Lunch. Today our speaker is Dr. Susan Pingleton, who's a professor of internal medicine. She has been a mentor to numerous folks in internal medicine, particularly in the division of pulmonary medicine and critical care. And Dr. Pingleton's been working with us on developing a mentor program for the Department of Internal Medicine, which is a massive effort. Very large department, and 70% of the faculty in internal medicine are junior faculty. So it's been a real challenge, and she's been working hard on that. And this is a really important topic because most of our physicians are so busy that they really have little time for developing scholarship. And the idea of developing scholarship and scholarly activity out of, I guess, what I'd call daily clinical work is really an important issue. So she's going to review some aspects of mentoring and then move into the main topic. So here's Dr. Pingleton.
Thank you.
Thank you.
Thank you. Can everybody hear me okay? Well, thanks for coming, everyone. This is a new talk, so you're going to be the guinea pigs on it. So when I get done, I would appreciate hearing if it's meaningful and beneficial for you. And it arises not only, as Bob said, from my interest in mentoring through the years that I've been on faculty, but also my last 2 years. And as many of you know, I've been on leave from the university for 2 years. In the first year, I was in Washington, D.C. At the AAMC, where I was a Petersdorf Scholar and learned a lot about quality, particularly on the national level. Last year, I was in Chicago at the University Healthcare Consortium, where I learned a lot about data, because the UHC has the clinical database. I know all the hospitalists know about the clinical database, and I assume from other departments you know about the clinical database. So I kind of got really into where's data that you use for quality improvement or research, and where do you all go to find it? So that's kind of my background as far as interest. So here's what I'm going to talk about today. First thing is why. Why should you junior faculty do this? Why should you have scholarship? And I will give my highly opinionated opinion about why you should. And the second thing is, what is scholarship? And you notice I didn't say research. Did you notice that? I said scholarship. And we're going to talk about the difference between scholarship and research. What are the resources you need? And one of the resources, as Bob mentioned, is mentoring and mentoring program that's going to go on in every department. We want to explore quality improvement versus clinical research. How do you develop a project, no matter in what area? Where to get the data? And then I owe Teresa, thank you for this, the Squire guidelines. This is a, let's see, something, I can't remember what the S is, strategy for quality and investigative research. Ooh, I'll show you the website. Well, I'll show you the road. God, that's embarrassing. This is, if I click here, it'll do it. Standards for quality improvement reporting excellence. Okay? These are guidelines that are an online resource for authors. So when you do get your project done, this gives you all the data about how to write it up. Now, how do I just... No, how do I get out of this? Okay. But we'll talk more about that. So again, why do we do this? What is it? What are your resources? Quality improvement versus clinical research, where to get the data, and then once you have a project, how to write it up. So, why? Why should you have some evidence of scholarship? Well, in my view, you are a faculty in an academic medical center. And while there's certainly nothing wrong with our colleagues in private practice, the expectations generally are different. Secondly, you need scholarship for promotion, no matter what track you are on. And we're going to talk about promotion in a little bit and faculty tracks. And I honestly believe it's the right thing to do for your students and your trainees. If you do scholarship, you're exploring different things, you're opening your mind to different mindsets, and I don't know how that can but help students and residents that you train. So, resources. The School of Medicine, as Bob mentioned, is now requiring every department, basic and clinical, to have a faculty development mentoring program. Pediatrics has taken the lead. Anybody from Peds here? There you go. Yay. The whole table. They are the only clinical department that has already started a mentoring program this last year, right? And every junior faculty has a mentor in Peds. And so the idea is to carry that on to every department. We're going to click on this. This is I want to walk through some of the Department of Medicine Mentoring Towards Promotion website. That's what I've been involved with along with Marty and Bob. And the first couple of things I want to make sure you understand is ranks and tracks. I suspect all of you know what rank you are, right? Assistant, associate, professor. How many of you know what track you're on? Everybody. What track is it? What? Clinical scholar. Actually, that's a pathway. But we'll talk about that. Well, I'm happy you know. So let's click on Mentoring Towards Promotion, and we'll see. I'll show you. Now, this is a fully developed faculty development and mentoring program, as you see here. The goal of the Department of Medicine is to mentor junior faculty through promotion. They have expectations, not only about promotion, but faculty assessment. We have a timeline. We have the core Center for Outcomes resource. And here we go. Getting ready to practice medicine, getting ready to research, getting ready to teach. Again, for junior faculty who don't know about the department, for example, if you were getting ready to practice medicine, you'd learn about Dr. Benson and Mr. Page and Dr. Norman. So these are resources for a new junior faculty to learn about not only their department, about the the whole academic medical center. How do you find a mentor? In medicine, you're going to find your mentor through your division directors. I don't think that's how you do it in Peds, is it? So let's talk about promotion and tenure. Understanding ranks and tracks. So here are the faculty ranks. You can be an instructor, an assistant professor, an associate professor, or professor. Do we need to turn some of these lights down a little bit? It doesn't look like it projects very well. Yeah, thank you. That's better. Okay. And if you read this, it talks about there are essentially two tracks, tenure track and non-tenure track. The tenure track has expectations that are different from the non-tenure track for promotion. And we'll go through those in a little bit. The non-tenure means that you do not have a set timeline to which to get promoted. If you're on the tenure track, you have 7 years to get promoted. So there's a clinical track, research track, and clinical scholar track. Now, there are two pathways on the clinical scholar track, the clinician educator pathway and the clinician investigator. As you might imagine, the clinical, again, these are non-tenure tracks, but the expectation of scholarship is higher on the clinical investigator path than the clinical educator path. I'll show you what the expectations are. Any questions about the tenure, non-tenure? Most of the new faculty are hired on the clinical scholar track, at least in the clinical departments, and on the clinical educator pathway. Now, let's talk about scholarship. Embedded in this is a definition of scholarship. And I don't think you can read this very good, so I have a slide. But the definition of scholarship is discovery and dissemination. You discover something and then you disseminate it. Traditionally, scholarship has been research, either clinical or basic, and research has been disseminated by presentations and publications. However, using a broader definition of scholarship, we can include in discovery quality improvement, curricular development, advances in educational systems, health policy and management. So these are the areas that discovery can happen that meets the criteria of scholarship. Dissemination could be, for example, if you had a curricular advancement, you would disseminate that advancement to other places, other medical schools around the country, without it being published. So this is a broader view of scholarship that I think is very important for our clinical faculty. So I guess the point is, when you hear the word scholarship and you're a clinical faculty, you shouldn't go, oh crap, that's research. Oh dear, this is recorded. So it's much more than research, and I think we're very lucky here at Kansas to have that broad definition, because a lot of places do not. They are traditionally research, basic and clinical research. Now, again, I'm talking about the clinical departments here. I'm not talking about the basic science departments. The basic science departments really need to have a higher level of scholarship because they have much less service. Okay, so that's ranks and tracks. So let's talk about promotion guidelines, okay? Now, if you're on the tenure track and you want to get promoted to associate professor, you need mid-career level in teaching, mid-career level in scholarship, and early career in service. So on our website, and actually this will be on the School of Medicine's website, so everybody will get it. So mid-career is a term that was defined several years ago, and it's like, what are specific expectations at the middle of your academic career that you should achieve? And you can see if you're a mid-career in teaching, you've developed and participating in teaching, you're supervising graduate students, you have substantial teaching and patient care. You don't have to achieve every one of these on either, but your body of work should include things such as this. Now let's go back to where most of you are, which are non-tenure track. And here we go. If you're on the clinical educator pathway, okay, of the clinical scholar track, you need mid-career in professional service, mid-career in teaching, and early career in scholarship. So let's look at what early career in scholarship means. Early career in scholarship is you've had a presentation or a poster to a local audience, a regional audience, for internists. The Kansas chapter of the American College of Physicians presentation would suffice for that. You can be a PI on a grant or a co-investigator. You can publish case reports and review articles. Those all meet the criteria for early scholarship. So it's not like you've got to go out and do a double-blind randomized controlled trial to achieve early scholarship. So everybody on the clinical educator pathway of the clinical scholar track, in order to be promoted, needs some evidence of scholarship. And I think these are reasonable things to achieve for an academic faculty. I don't think they're onerous, is what I really want to say. So you can, what we put together is promotion, associate professor, professor. So every faculty member can access these at any time and know exactly what the requirements are for promotion, depending on what track they are or what pathway they are. Any questions about that?
Sue?
Yeah.
I'm trying to get this thing to work. Oh well.
You got to
shout.
Yeah, just
This
shout.
won't be on the recording very well. While you say the broadening of scholarship affects mostly clinical faculty, just the list you had up there, our basic science departments now include health policy management, history and philosophy of medicine, and have always included preventive medicine, which over time has broadened over the time that you and I were on the School of Medicine PhD committee, about 10 years ago together. I mean, we have a much broader view across the board, not just for clinical faculty.
Yeah, that's a very good point. You know, the department, Dr. Cox heads up the Department of Health Policy, Dr. Ellebeck, preventive medicine. So those are departments that aren't traditionally clinical, but yet these guidelines may apply for. Any other questions or comments? So, like I said, this is all going to be oh, I'm sorry.
One of these to work.
Yes, please.
For promotion to associate, assistant to associate, you mentioned all those things, but what about? Should I repeat? Okay, so for promotion to associate, from assistant to associate, what about numbers as far as how many presentations, how many posters? Is there a usual recommendation? I'm sure one is not going to suffice. 20 might be too many. So
no.
is there
No.
a number that you recommend as far as?
There is no way to quantitate that because some people on a P&T committee would think that 5 case reports equals 1 prospective study. So it is the quality and the character of the study as well as the number. So particularly on the non-tenure track, I think a number's hard on any track because you've got to evaluate the individual paper and where it's published or presented or where the impact of a curriculum is. I mean, do you have any more to add on that, Bob?
Years ago, we tried to actually develop a scorecard, and I remember it got vetoed by one of our deans, but I think it was a really bad idea. But people sit around and go, well, I needed 15 points, and you say I had 14, but I really think it's 15. So it really is the body of work that people will look at. The example I always give, I'm a basic scientist by training, so if someone has a paper in Nature Medicine, that's probably worth 3 or 4 papers in a third-level journal. And so people the reviewers try to look at lots of things, but impact. Is your work known? Has it been disseminated appropriately for the field? If it's quality improvement, is it in those journals that people would read? And the other example I always give is Southern Medical Journal is distributed to thousands of doctors' offices around the country. Probably a whole lot better read than Nature Medicine in terms of numbers. Yet if people look at quote, impact factor for Nature Medicine is something like, I don't know, Matt, maybe 19 or something. Yeah, close to 20. And Southern Medical Journal is 0.6. Well, it's based on the number of citations that paper is quoted X number of times if it's published in that journal. It's an artificial measure. So people will look at, is it appropriate for the field? Is it appropriate for the person's career that they're disseminating their work? I keep using the word appropriate, but that's the best word to use. Is it appropriate? Does that help?
Yeah. So I think that's a very good question. And this is something, as you have a mentor, you and your mentor need to discuss and get his or her advice to you as far as what Bob's points were, the impact factor, the appropriateness. I guess the thoughts I would leave you with is you need some scholarship, okay, if you're on a clinical track. 0 won't get you promoted, and I think you should get promoted. You're bright, talented, capable people, and there's no reason why with some resources and support that can't happen. I want to show you one other thing on our website that I hope will be helpful. Then this only will be in the Department of Medicine's website. And what it has is a timeline. What should you do when you sign your letter? What should you do on the first day besides find the bathroom? So HR, TB skin test, where you eat. Okay, that's your first day. So we tried to make this real practical. The first month, it gives you some information. Where do you get computer and software resources, teaching resources? In our division, the curriculums will be up there, the divisional curriculums. Here's where you learn about professional development. Here's CME. Here's library resources. So again, that you don't have to go cast around by yourself to find this stuff. But when we start at year 1, we now say, here, your first annual assessment, many of you have just filled that out. You should set up your teaching portfolio, and this tells you how to do that at year 1. And then it also tells you where should you be. What should you have accomplished? If you're on the clinical educator pathway, in year 1, these are the things we think you should have done in year 1. Likewise, if you click on year 2, you'll see this, year 3, year 4. In other words, you need, from the get-go, you need to be planning what you do, okay? It doesn't mean you have to achieve every one of these, But this is, I think, a common sense approach to how to look, and it only goes to year 5 and 6 because there's year 5 and 6 is when the tenure track people have to go up for promotion. But there is getting to be a feeling, at least in the Department of Medicine, at years 5 and 6, the clinical scholars ought to be thinking about getting promoted too. And in my opinionated opinion, we've swung too far to kind of reassure people, oh, you don't need to worry about it. There should be scholarship, and there should be some sort of timeline. Maybe it's not, I mean, there's no structured timeline, but in your head, you should be planning from day one so that at years 6, 7, 8, then you go up for promotion. Okay? So we hope that's going to be helpful. Now, so that's our website. Yeah.
Question about for non-tenure track faculty, is there anything that can do the mid-cycle review? Sorry. For tenure track faculty, they get a chance for the mid-cycle review that could tell them whether they're on the right kind of path or not, with some time to correct things. Is there anything like that for? Would you like the microphone back?
It's a really good question. We've thought about it. We don't exactly have a large professional development faculty affairs office. It's 2 people. Marty does all the faculty development, and Joe does all the faculty affairs, including promotion and tenure. Until the last budget crunch, we had a position and a half that were justified and supposed to be up there now, which would help tremendously in terms of trying to take that on. But that would be really nice. People get really angry when I talk about the California model, because I'm not somebody who says everything in California is good, or at this point anything in California other than the weather is good. But the California system really focuses on promotion for everyone within the same time as tenure track. So 7 years, the expectation, at least for that first promotion. And of course, they have a very stepwise system, so it really works out very nicely the way they have it set up. But I'd like to see people promoted at 7 years, and really essentially from associate professor to professor in about the same time. I think what we have right now is a system where with clinical scholar track, people are going to come in as assistant professor and maybe sit there for a very, very long time. In some cases, maybe for a career. And I don't think that's good for an academic center. People have things to contribute in terms of scholarship. I think Dr. Pingleton's made one of the best definitions of scholarship that I've heard, and also one of the best reasons for why scholarship's important in terms of educating students and trainees all the way through, and the whole thing of building an academic health science center and keeping it going. But yeah, I'd love to do that. We just don't have the staff to do it, and maybe we could do it more informally at a departmental level, that in addition to annual assessment, let's say at year 3 for all assistant professors on no matter what track, that there's kind of a cumulative assessment.
You know, Sally, that might be easier too when we really get a formal mentoring program in the department. That because I've asked Dr. Stites for some resources to help organize the mentoring program, and that I'm really glad you mentioned that, because I would think maybe with some resources we can organize ourselves to get that done. I think that would be very good. So mentoring. Before I go any further, yes.
Let me ask a quick question. So how would you advise a new faculty member whether to choose the tenure track or the clinical scholar track?
Why don't you say it again for the record?
Sure. So how would you advise a new faculty member on how to choose? I think it works. I can't have it back. I asked Dr. Pingleton. How would you advise a new faculty member to...
He wants your advice, not mine.
I got to finish this question for the
Okay.
record, right? Whether to choose a clinical scholar track or an academic or tenure track.
Well, that discussion should be between the faculty member and the chair, in conjunction with the dean for faculty development, which is Dr. Klein. But it should be a discussion. And I know Bob has pretty strong feelings about that, but there should be some discussion, and there should be understanding what tracks you're on and what the expectations are, and what what background somebody has that would allow them to succeed. I believe we have too few tenured faculty now. And, you know, when old dinosaurs like me go away, I mean, who's going to be on the P&T committee and who's going to be on the admissions committee? So, anyway, Bob, why don't you share your opinion, too?
Well, for the first time, we have people going in both directions. Most frequently, they've been going from on clinical departments from tenure track to clinical scholar track. We've started to get people going the other direction. That people have come in, and I'd almost prefer that they come in clinical scholar track, get their feet wet. It allows a lot more flexibility in terms of the system. It's true that once they come on tenure track, they would still have a tenure clock that starts at that point, but it allows us a little more flexibility with family leave issues, with maternity, paternity issues. It really is helpful to the system. There are other schools like University of Nebraska where everybody comes in kind of in an undecided mode, and then after 6 or 7 years they have to fall into one track or another. In some ways, if you can keep control of the system, that's probably a good way to go. But the discussion, as Sue summed it up really well, it's between the faculty member and the chair, and usually our office is involved a little bit. But trying to look at what activities someone's done before they've come here. If they've been very limited in their amount of scholarship, then clinical scholar is probably a really good place to be. If they've had a fairly strong record of fellowship and publication, then maybe tenure track right away, or I would actually opt to put them on clinical scholar track for a couple of years, let them ramp up their activities and kind of expand that, because we say 7 years for tenure, but it's really 5 years and 3 months. And that time just flies by. And lots of people who've been through the system understand that. It just goes quickly. And then you add birth of children, family issues, changes in a division where it's dropped from 5 to 3, and now people are on call twice as frequently as they were before. Tenure track just is very locked in, and so I'd almost like to kind of modify and say come in on clinical scholar track, ramp up, and then switch. But does that answer the question?
Yeah, I think it's a good answer.
Yeah. But I'm not happy either with the fact that we are going to reach a point where we can't find enough tenured faculty from clinical departments to sit on P&T. And I don't think anyone really saw this. They said clinical scholar track is wonderful. This is unmodified title, rolling contracts, has all these great things, and no one really looked at the future of, not just here, across the country, academic health science centers, and say, well, but the basis of our P&T committee, that's really the one committee that requires tenured faculty members, supposedly with basically no axe to grind. They're already at the upper level. They're not going to be, their promotion is not going to be dependent upon anything that happens in the committee. It's happening in every medical center across the country, where years ago it was just the schools that didn't have a tenure system, like were very limited, like the Ivies, and so it's a complex problem.
Yeah, and as someone who sits on the P&T committee, there were several people that could have been promoted on the tenure track, in my personal opinion, that were on the clinical scholar track. Not that anything's wrong with it, but they had the requisite expectations. So chairs and departments need to look at their faculty and see if someone's just on the clinical scholar track and really doing well, whether that person should be considered to transfer to the tenure track. So, by the way, how many of you junior faculty have mentors? Okay. How many don't? Okay.
We've got to fix that.
Yeah. How many are mentors here? Great. Okay. Good. Well, we're well on our way, aren't we? So again, scholarship, traditional research, quality improvement, education curriculums. And I'll spend a couple minutes about quality improvement because a lot of you are involved in QI in the hospital. In the last year, the internal medicine chairs were surveyed about quality improvement. They feel like 80% of them felt like they had faculty with more than 20% QI. And for internal medicine chairs, it's pretty amazing. Almost 80% thought that they should be promoted based on QI. And they do, a minority thought that scholarship or academic progress should be required. Few consider it service. So here's an opportunity. This is taken from an article that was in JAMA in February of 2009. It's a very innovative article written by Wendy Levinson, who's the chair of medicine at the University of Toronto. And she compares and contrasts traditional research around quality and quality improvement. This is traditional research. This is, very prospective, large-scale studies, description. The interventions can be descriptions of analyses and identification of problems. And, for example, a rigorous evaluation of a novel QI intervention. That's traditional clinical outcomes research. Now, she makes the point that there's a difference between routine local QI and innovative QI. Routine local is some performance data that the insurance company wants, or membership on the critical care, critical incident review, or modifying a national practice guideline for a local. There's nothing wrong with that. It's service, but it's not scholarship. She tries to make the point that there's something called what she calls innovative local QI. For example, a measure could be a multidimensional quality report card. You could intervene by modifying incident reporting systems, or an example is you could lead a complex QI undertaking like you guys are doing in the hospital. So I found this very intriguing, and just as an example, routine quality-related activities, the general internist who led the local adoption of national guidelines is on the Hospital Pharmacy and Therapeutics Committee and sits on another hospital committee. This is hospital service. There's nothing wrong with it. You need service as far as your expectations, but it's of little intrinsic merit. However, here's an example of a clinician engaged in innovative QI. A hospitalist who during his or her non-clinical time led the development of an innovative program to improve the discharge process. That's the discovery part of it. The dissemination was that successfully led to hospital-wide implementation. It was disseminated locally. But I agree with Wendy that this is discovery and dissemination. So this is probably the most fertile area to think about as far as QI projects that can be academic. So how do you develop a project? Well, you can get assigned a project by your mentor, but my entire academic career has been based on having an interesting clinical problem that I didn't know the answer to and couldn't find an answer to. I've listed 4 examples of people that I'm mentoring who this is their question. We sat down and I said, what are you interested in? One of them is, does routine phone call after discharge improve discharge planning? Does the serum lactate predict mortality in a retrospective review and acute bowel obstruction? What interventions in the EMR can improve core measure compliance? What are the benefits of a hospitalist administrator on duty? So these are, and this one in particular is very innovative in the sense of it's a new kind of administrative position that hasn't been described before. So all of these are projects people are working on, and they really came about because they were interested in this area. So I think the most fertile ground is to find out what you're interested in. And then go see if anybody's written it up or if there's any information about it. Lastly, I want to talk a little bit about data. If you have a project, you're going to have data to prove something or disprove something. So let's talk about what is the role, what are the sources, where do you get data, characteristics of good data, and then I want to talk a little bit about administrative databases, pros and cons. So there's lots of data sources. Starting over here at the right, clinical trials. In fact, there's a clinicaltrial.gov website that talks about all the clinical trials of the government. Registries by specialty organization, industry registries, states, we'll talk about that in a minute, and then clinical data. Clinical data that's abstracted from the chart, or O2 now, and administrative databases, which can be proprietary. Here at KU, we have the UHC clinical database, But the people out at the VA have the government. Well, this is one of the most incredible registries and clinical database around. So registries, a lot of specialty organizations have registries. The CTS people probably do it the best, and they have been so smart about it. They get the hospital to pay for the people who enter the data in their database. Anesthesia Quality Institute data registry. My own organization, the American College of Chest Physicians, has a bronchoscopy registry. Diseases, the cancer, the University of California in San Diego, which is one of the primary places for pulmonary hypertension, has their own pulmonary hypertension registry. And then governments, the CDC, as I said, the VA. The state of Kansas has 10,000 diabetics in a diabetes registry. So there's an amazing source of data. And Sally, you get your data from the Medicare database?
Yeah, Medicare and Medicaid, but if you purchase it through CMS. The other thing there is, though, there's a lot of publicly available, downloadable. There are also available a lot of surveys, epidemiologic surveys, but some of them have direct patient-level data in them that are publicly available or purchased on the cheap, $100 for a CD. There's ones for hospital medicine, there's outpatient ones, there's nursing home, there's the METS Medical Expenditure Panel Survey ongoing. So there's a lot of already pre-developed and data-populated things that are ready to be analyzed that we need to wring the good stuff out of.
Right. Then, if you know where the database is, all you have to do is ask the question. Query the database. I mean, it's amazingly simple. I know Sally's groaning when I say that. So let's talk about administrative database. Well, let's talk about where you get clinical data, okay? You can do it in a prospective way, chart abstraction, and the NSQIP, National Surgery Quality Improvement Program, is one of those programs. However, it's expensive, labor-intensive, but the physicians love it. Administrative database, this is, like I said, this is what we have here at KU, but Premier and Thomson Reuters also have a clinical database. These are claims data that's always retrospective, and we'll talk about it a little bit, but it's a very efficient way to collect data. Chris Witkoff is kind of the clinical database queen around here, along with Kathy Gardner. And, if you had a question, if you wanted to do a retrospective study of Tylenol overdose or liver failure, I mean, she can get that data for you in the sense of who the patients are. And then the new hybrids are those that are clinical database, but you can link them up to resources, like of your patients with Tylenol overdose, how many had to be in the ICU, or how many had this drug or that drug. So it's a very rich database. Where does it come from? It comes from the face sheet. Physician documents the care. The coders are assigned codes to diagnose and treat them. And one of the reasons KU has such a high quality score is they have excellent coders. And coding can make all the difference, not only in reimbursement, but quality levels. And then you get a claim, and it has what you might expect: patient demographics, diagnosis, procedure, length of stays, etc. That data goes to several places. First of all, it goes to the insurance company so the hospital can get paid. It may go to the state if the state has some sort of requirements. For example, the state of Kansas has just developed a healthcare associated infections not request, demand really, where you have to submit the healthcare associated infection. So depending on what state. And then if you're a member, if you pay for this service, the data is shipped to UHC and it's scrubbed and diced and risk adjusted and then sent back to the hospital. So it's your own data. I mean, I don't think there's any easier way to get retrospective data. Now, it used to be there wasn't a very good correlation between chart abstracting and administrative data, but that's different now because the risk-adjusted models are very strong. You can see the correlation between data that came from somebody looking in the chart versus data that came from a clinical database, and the correlation is very, very good. So if you do use a clinical database, it must be risk adjustment. And risk adjustment is you take all the people and your statistical analysis risk model, in the low risk group, not very many people should die. But if you're deemed high risk, then most everybody ought to die. And what are the inputs? Their age, sex, whether you come from a nursing home, whether you're a ventilator on day one, whether you have cancer, diabetes. I mean, those are the things that you need to do for risk adjustments. So, lastly, standards for quality improvement. Here's the Squire guidelines. I'm going to click on them. So it tells you title, abstract, introduction. This is how you put it together. Methods, planning the intervention, planning the study, analysis, and results, outcomes. So it's a walk-through guide, and there's a checklist in the PDF form, which now this was designed primarily for quality improvement. If you do a quality improvement project that you want to write up, remember you're going to have to go through the IRB. You do have to do that, and I think that's perfectly appropriate because if you're going to get published someplace, it needs it. So this is a resource. Just Google Squire, and you'll get it. And I think it's a very, very nice link in the sense for people writing it. So, scholarship out of clinical work. Scholarship is discovery and dissemination. All departments will have resources for you for mentoring. QI versus clinical research. Well, what are you interested in? Where to get the data? Registries, clinical database, O2. And in that vein, one other thing, where to get the data, I would encourage you all to think about the health of the public students. Are you all familiar with that elective? It's a fourth-year elective, and there's groups of students, and they need projects. They essentially need QI projects. Mohammed's working with one of the groups of health of the public students. These are scribes. These are people who will do your legwork for you. They do it 3 times a year. They're a month at a time, October, February, and April, I think. And you just have to give, what's her name, Nancy Sullivan? Leslie Sullivan. Let her know you're interested, and then write up a project. Mohammed wrote up less than a page project, and then she'll do what she needs to dispense it to the students. So it's a very good way. Now, you're not going to cure cancer in 1 month study, but some of these studies, like Arut Paul is doing the BOOST study, and about every time he has a group of students looking at one aspect of the BOOST. So keep that in mind. For busy clinicians, you have people who will do the work. It's very important. And then the Squire guidelines when it's all ready to be written up. So I think that's it. Questions? Yeah, Sally. You want to turn up the lights, please?
Not a question. Just a quick comment. Along with the Squire guidelines, there are also a bunch of these for other types, like for meta-analysis, for clinical practice guideline development. There's guides for how to write them up and get them published, and there's an umbrella, and now I can't remember the name of the umbrella organization, but I'll send it to you, that has all of them. So Squire is one among like maybe 10 different. The Consort was the first one for RCTs. There's one for diagnostic studies. There's one for meta-analysis. There's just a whole set of them.
Okay, thank you. I don't have a watch. What time is it?
It's 4:02.
I'm sorry. Is there a question over here? Yes.
So what do you do about your faculty, clinical faculty, to say we don't have any time to do unfunded research? And that's the main kind of objection that I hear to being able to accomplish anything like this.
Yeah, it's a real problem, isn't it? That's why I was so excited when the idea that you're going to have a mentoring program with resources for the faculty that can help them, and to develop a project and then go get the data someplace else. There isn't an excellent answer for that. It's very hard. Some of the faculty are 95% clinical, and it's very hard. So mentors, I think, are especially important in understanding that and working with the faculty to engage the health of public students to do it, or do a retrospective study that utilizes a clinical database, something doable. And I don't know if there will ever be a time when that's supported. It seems really hard right now with the finances the way they are. I'm glad you asked that question. So what we were going to do now, if you're interested, is have kind of small, 5 or 10 minutes, talk among yourself, and after this information, we'll go back to you and just give us an idea of what some things that you might like to do in some sort of a clinical project, okay? And I'm not going to make you move, even though if I would have done it from the start, I would have had you all sit together from one department. But why don't we do it?